For this project, I decided to focus on feeding and swallowing issues in the NICU and the role of the SLP. Feeding and swallowing skills is a large area of practice for medical speech-language pathologists in the adult population. Over the years, the pediatric population in this realm of practice has grown and created another specialized area in our scope of practice. Specifically, preterm infants in the NICU are predisposed to feeding and swallowing issues due to immaturity of their anatomy and physiology, medical complications, and medical treatments. This has resulted in the emergence of the critical role the SLP plays within the medical team that treats this population. With this population being such a specialized and sensitive group, ASHA has outlined the basic competencies of knowledge and skills that SLP must possess in order to fulfill the various roles and responsibilities they have within the NICU. Among the responsibilities include assessment, intervention, and education and counseling. Each case within the NICU is unique, and there are a variety of assessment and intervention approaches that can be utilized to promote optimal outcomes. It is the SLP's ultimate goal with this population to support safe and adequate nutrition and hydration, determine the optimal feeding methods and techniques to maximize swallowing safety, and promote positive oral feeding and experiences to prevent further issues. The scope of practice for an SLP includes feeding and swallowing disorders due to the fact that we are educated and trained in working with the structures that contribute to these processes. Feeding involves the skills of gathering, preparing food and liquid for intake, and swallowing is a complex process of 3 phases: the oral phase, pharyngeal phase, and esophageal phase, all of which contribute to getting the food from the mouth to the stomach. Feeding and swallowing disorders are seen in a range of population. Mostly we've seen this with adults, but increasingly we are seeing it in the pediatric population. Specifically, we have seen an emerging role of the SLP working with preterm babies in the NICU. A preterm baby is a baby that's born at or before 37 weeks, and a NICU is an intensive care unit for medically unstable infants who require life-sustaining treatments or surgery. We see these kids due to the various factors that impact their feeding and swallowing, such as their anatomical and physiologic immaturity, medical complications, and medical treatments that can impact their feeding and swallowing abilities. With this emerging role, there are various responsibilities outlined by ASHA necessary to be a competent SLP in the NICU, such as assessment, intervention, and counseling and education. Additionally, working in this population, SLPs work as part of an interdisciplinary team and with a strong family-centered approach so that we can address their multiple medical complications and their developmental outcomes. For the literature that revolves around this area of practice, there has been research in various literature that touches on the emerging role of the SLP in the NICU, the premature infant feeding and swallowing development, and support for various feeding and swallowing interventions in the NICU, all of which I will cover, starting with the reasoning behind the emergence of the SLP's roles in the NICU. Over the last few years, we've seen an increase in pediatric feeding and swallowing issues, and a main factor that influences this change in caseload in relation to the SLP's role in the NICU is seen in the research that the survival rate of preterm infants has increased by 20% since 1990 due to advancements in medicine and development of higher level NICUs. This end result we end up with babies that have more medical complications that need attention from various specialists, including an SLP, as seen by the fact that feeding difficulties and behavioral feeding issues occur in approximately 85% of medically complex children. Another 2 factors that influence this change in caseload is federal legislation that requires early intervention as early as birth, and evolving theoretical foundations that focus on family-centered care to promote developmental outcomes, including feeding and swallowing skills. Additionally, the literature has also provided information towards premature infants' development of feeding and swallowing. Research has shown that a delay in acquired feeding skills is the most frequent cause of prolonged hospitalizations in premature infants. There are various factors that influence feeding development in both term and preterm infants. Research has shown that these include primitive reflexes, nutritive sucking, coordination for respiratory system and feeding skills, oral readiness, which depends on physiological stability, alertness levels, and successful non-nutritive sucking, and caregiver and child interactions. When these factors are disrupted due to prematurity, they will have implications on feeding, as seen in the research. Additionally, the research has shown that this population is at a risk for higher risk for feeding and swallowing issues due to their increased likelihood of experiencing various medical comorbidities, such as respiratory issues or gastrointestinal issues, among many others. So, lastly, the literature has also provided support for various intervention methods for feeding and swallowing issues in the NICU, all of which the SLP can assist in initiating or implementing. Some interventions that have research to support them include the transition from volume-driven to cue-based feeding, which is basically a shift in, instead of only focusing on how much you can get into the baby and how quickly, you focus on more of reading their cues for readiness to feed. Additionally, oral motor intervention, oral stimulation, modifying fluids and food, special feeding equipment, and special feeding strategies are all intervention approaches that have proven to be effective within the research. And I'll go into these in more detail in later slides. So for the clinical implications, as talked about previously, the emerging role of the SLP in the NICU has elicited a position statement and technical report from ASHA that outlines various knowledge, skills, and responsibilities that SLP must know and practice when working with this specialized and sensitive population. Some knowledge that they're going to need is about infants and their development, typical and atypical feeding, and the NICU environment and the various medical equipment and feeding options they're going to see, and the responsibilities and roles it might include within the NICU is assessments and evaluation, interventions, using a team approach, and family and professional education. So to get started, I'll go into just a surface of the basic knowledge to support practice within the NICU. So we're going to need to know about the infant development in relation to feeding and swallowing skills. So knowing about anatomical differences, such as the fact that they have a small oral cavity and their larynx is higher up to help protect their airway. We need to know about primitive reflexes and the fact that they support feeding skills and they begin at 26 weeks, such as the reflex of suckling, rooting, and tongue protrusion. We need to know about nutritive and non-nutritive suckling and sucking. Nutritive sucking is used to obtain nutrition, and it provides an early oral motor experience that is essential for oral sensory motor development, and it's also an experience for infant and caregiver bonds. And non-nutritive sucking is more so for the infant to pacify themselves and regulate their state. We need to know the importance of their ability to coordinate a suck, swallow, and breathe in order to be able to successfully orally feed, which begins at 34 weeks. And additionally, we need to know about their levels of alertness and their different nutritional and energy needs. As for the atypical development of preterm and medically complicated infants in the NICU that require SLP service, we need to know about the potential factors that can interrupt their oral feeding and swallowing development in the NICU, such as their state control, which is dealing with their level of alertness. The optimal state for suckle feeding is an awake alert or awake active state. We need to know about their stress levels and what could be causing them and how to observe them and respond to them. We need to know about postural control and how it can support efficient feeding. We need to know that oral motor control is also important and that many preterm infants display an absent or abnormal oral reflexes, which can impede their feeding abilities. We need to know that an immature GI tract will cause difficulties in digesting their feeds. We need to know that physiologic control is important in coordinating feeding and swallowing, and that their physiological responses to the work of feeding may be impacted and may ultimately cause feeding and swallowing to be more difficult. We also need to know that respiratory and heart rate may be a factor that makes feeding and swallowing more difficult, and ultimately that impacts their endurance to keep up with the energy needed to feed. We need to know that suckling, swallowing, and breathing processes are controlled by the brainstem, and in premature infants, these control centers may have not had the chance to develop yet before they are born. So this is going to impact their ability to coordinate such a process. And also we need to know that long hospital stays, physiologic instability, lack of state control, noxious environment, stimuli, and parent and caregiver reactions all will impact their suckle feeding interactions. Overall, we need to know this population is put at high risk for penetration, aspiration, and malnutrition. Lastly, some basic knowledge will include the NICU environment and understanding different medical equipment we might see, different medical professionals we might work with, and different enteral and parenteral feeding options that we might see being used. So now the service of basic knowledge needed to be SLP in the NICU is covered. I'll begin to talk more about the responsibilities of SLP in the NICU, beginning with assessment and evaluation. We'll need to do a case history. We need to know about their current status, their social history, medical history, and feeding and swallowing history. We need to address their behavior, state, and sensory integration levels as these impact feeding. We need to know about their respiratory function and endurance. We need to do an oral mechanisms exam to see how their structures are functioning, and also to address cranial nerves within this. part of the exam, such as the trigeminal, facial, vagus, and hypoglossal, to see whether or not they're functioning the way they are meant to be functioning, since these all can impact feeding. We need to address nipple feeding evaluation to address the oral preparatory and oral phase of swallowing. And additionally, we need to think about the potential usage of instrumentation to look at their pharyngeal phase or esophageal phase of swallowing. As for intervention, there's different types of intervention that we can see used. Our primary goal, though, is to establish a safe and efficient way to orally feed that is developmentally appropriate. There's going to be different types. So compensatory strategies are meant to ensure successful feeding in the presence of an underlying disorder. So we can establish optimal infant state and readiness to feed. So this kind of plays a role in cue-based feeding. So basically making sure that they're ready to feed and we're responding to their cues. We can alter the environment, such as feeding them in a calm, quiet place. We can change positioning to reduce the risk of aspiration. We can alter the consistency, temperature, volume, and taste of food. Or we can alter the feeding utensils used, such as altering the nipple size, shape, flaccidity, stiffness, and flow rates. Facilitative approaches promote and or develop normal feeding skills. So some methods here is establishing a non-nutritive suck, which is a prereq to nutritive sucking. We can establish an external pacing method to help avoid potential fatigue and coordinating timely breaks for rest during feeding. We can use oral stimulation methods, which is stimulating the face and oral cavity with different textures and touch pressures and temperatures to help develop skills and decrease oral aversiveness. We can also use oral motor therapy, which focuses on increasing or decreasing oral tactile sensitivity, oral facial tone, and stabilizing oral movements. Lastly, we can use developmentally supportive care in conjunction with any of these methods. One example of this is kangaroo care, which is skin-to-skin contact between the infant and caregiver. This helps babies become more relaxed and content and facilitates infant and caregiver bonding, which is important for feeding. We can also use non-nutritive sucking or non-nutritive sucking into breaths, which will promote physiological stability and nutrition in preterm infants and will prepare them for breastfeeding. Two last big responsibilities of the SLP in the NICU is utilizing an interdisciplinary approach, as this is a team effort to care for and stabilize these highly sensitive and complex babies, and also utilizing a family-centered based approach based off the consideration of family interactions and their impact on the preterm infant and their development. And also the fact that we need to respect cultural and family values. And a huge part of our practice is family education and counseling, because the infant is a passive receiver of services and the family and caregivers are ultimately who are going to be implementing these feeding strategies once they're discharged from our services. In summary, the NICU population is a sensitive and specialized population that requires extensive care from various medical professionals. Various factors impact their ability to orally receive nutrition efficiently, which can have significant impacts on their developmental outcomes. This aspect of this population is what elicits the services of the SLP. The SLP must have specialized knowledge and skills towards this population in order to effectively and efficiently fulfill their roles and responsibilities of assessing, intervening, and educating and counseling. And these are my references.